for joining me on a Thursday afternoon. As I promise you, this is going to be very good information, and then I would value feedback and questions, and hopefully we can spend a good amount of time there. So I'm going to start with the slides here. Thank you. Great. Just go one at a time. Great. So we're going to talk about COVID. So in the Far East, they came up with some treatment strategies that has been very, very effective. I'm just going to say where it is. It's from Bangladesh, and you'll know why in a minute. And then Australia took it up, and then now there will be some science journals that's going to publish this novel treatment. And as I said, it's new here, but we've tried it and it works. So go to the next slide. So I'm just going to go through the clinical presentation really, really quickly. So this is somebody who's 66 years old. We saw them on May the 27th. So to the left, you see the symptoms. The symptoms started off fairly non-specific. For the first 5 days, the lady had a headache, wasn't feeling very good, a little fatigued. There was pressure behind the eyes. What was concerning was the sweating at night, particularly. So the question is, did she have a fever? They didn't actually document a fever until many days in. By day 5, her fevers had started to go up to like 102. And as a baseline, she'd already had joint problems, but the joint pains just seemed to be above and beyond. And so, from the time we met her on May the 26th, that we kind of had a suspicion that this could just be a viral infection. It could be something fairly benign. What's not written on here is that as the days went on, she started to have more of a dry cough. And then what was worrying is that shortness of breath, because as you know, with COVID, shortness of breath can be the beginning of a kind of a protracted course. So that was kind of concerning for us. So the next slide here would go over some of the evaluations that we found, okay? So she was actually somebody that had normal blood pressure. I may have inadvertently said that she may have had blood pressure, but going back to my notes, she had actually had normal blood pressure. Heart rate's a little bit high there because usually resting heart rate is about 70, give or take. If you're very conditioned, then it becomes like less than 60. And super fit people have even lower heart rates. The temperature, when we measured, it was 99. When someone tells you they're sweating, you always should suspect fever because, when you have a fever, you sweat. And after sweating, then people can sometimes feel cold. We call that chills. So when someone complains of sweats and chills, they may as well have fever, whether they detect it or not detect it. And for us, oxygen level of 96% is pretty much normal as far as we're concerned, and 96, 97% or more is all normal. And so that's something that if it was lower, then that's somebody that we would very significantly think about considering sending to the hospital as a kind of a precautionary measure. What's very important about COVID patients is that their lungs are clear when you examine them. They have this dry cough, they may have shortness of breath, but the lung exam is very normal, and that's true of the rest of the examination findings. Really, there's no examination finding. So the next slide is going to be much more important. So, but the question is, what's my thought process? Look, everybody that comes through the door is not necessarily COVID. In fact, we don't allow people to come through the door that's COVID. So this is somebody that just wasn't feeling well. The body was hurting, the joints were hurting. So it could be a common respiratory virus, right? And so there's so many. There's the respiratory syncytial virus. COVID is one of the coronaviruses, but there are other coronaviruses out there. And it could have been allergies, right? But the fever kind of gives it away. When someone's got a dry cough, you have to think about respiratory problems like asthma. And I just put this for possibilities. It's not something that everybody that walks through the door is going to have a collapsed lung, which we call a pneumothorax. But COVID-19, appropriately written in red, is something where you have to think about it. So the patient was wearing a mask at all times, which is reassuring because you don't want to spread this to the caregivers like myself and so forth. So the next slide goes into the nitty-gritty of, what do we do? So when they first came in, we didn't know what it was. It could have been just a little old virus. You're not going to over-medicate somebody. You're not going to give them a whole bunch of, now there's, for very seriously hospitalized patients, they're giving dexamethasone, which is a very powerful steroid, but you don't give that to prevent the COVID. You don't give it at the mild stage. You don't give it when they have even a little bit of shortness of breath. It's really for the people that have they're intubated, they have cytokine storm, they're in respiratory failure, and then the steroids really bring down the survival or increase survival by 30%. So my point is that you just can't throw everything at people. So within the one day, the labs came back in. So on May the 27th is when we saw her. We had a suspicion that it could be COVID, but we ran a full spectrum of blood work looking for maybe other viruses or some other problem. You know, if we didn't know that she's diabetic, maybe diabetes and high sugar can give you fatigue and dehydrated, things like that. So what we found here is that the reference range for this COVID antibody testing, it should be either initially a positive or negative test. In her case, it came positive. Then we do what's called an index. That means there's a reference range you see on the right-hand column, and that when it's above 1, then that's positive. But hers was more than positive, it's 60. That's pretty impressive. And then not only did she confirm to have COVID, we know that COVID patients can have elevated liver enzymes. 2 of the enzymes that we measured here were AST 45, ALT at 47. So these are definitely elevated. And then the inflammation marker, which is a C-reactive protein, and anything less than 3.1 is acceptable. Hers was 9.4. So fast forward, what we had to do is decide that, look, this is somebody that had problems, had symptoms, and by the time she came to us, she had symptoms for about 5 days. So when you're doing antibody testing, and this is some of the questions that may come up, is that when do we do testing, right? When do we do a nasal swab? When do we do a blood test? In this particular patient, we didn't know that she had COVID, but we know that the antibody test can pick up fairly acute cases. So by day 5 to 7, you have a very high chance of picking things up on a blood test, looking at IgM antibodies. And then if people have been exposed to something for maybe over 2 weeks, then the IgG comes and stays up for some time. Again, how long it stays, we don't know yet because it's such a early kind of condition. So based on my diagnosis, particularly on the labs, I said that, so I'm going to treat this lady, right? So without her coming back, we had to give her this treatment. I'm going to go over what that treatment is, but what was the result of that treatment? That treatment resulted, after 3 days, fever coming down, sweats disappearing, joint aches going back to normal. She had arthritis, so it went back to baseline. The shortness of breath wasn't there. The cough was a lingering cough, but that took another 7 days to get better. So that is a pretty rapid recovery in a documented positive case of COVID. So the next slide will show, you know, what is it that we used? The Far East, as I said, Bangladesh came up with 2 treatments, and each one was just 1 dose. 1 dose of an antibiotic combined with 1 dose of an antiprotozoa. The antiprotozoa is actually a diarrhea medication. And the reason why Bangladesh is ahead of the curve is because, unfortunately, that's a big problem in Bangladesh, right? Typhoid fever, lots of gastroenteritis. So it's not a great claim to fame, but we're good at something. We're good at that shit. I mean, you know, medical shit. We're good at that stuff. And so they saw this promising use of this 1 dose because it doesn't get absorbed into the body. It stays in the gut, leaves the gut. It's designed to break down protozoa so you can treat diarrhea, infectious diarrhea, and in combination with antibiotic. Now, the reason I didn't actually write it down is that even though I'm a little bit ahead of the curve on the Western hemisphere, in the East, they're doing it. I don't want to be too ahead of the curve and haters coming at me and trying to show me where's the publication. The publication is coming. As soon as the publication comes, I will tell you what it is. And if people want to reach out to me directly, and certainly if you have sick people, I can test for it. I can look at all the other parameters that confirm things like ferritin. You know, I only had positivity in liver enzymes and inflammation, but there are a few other markers. So if we find somebody with infection, instead of saying go home and quarantine, I can actually do something. And as Eric knows, I do more than just the prescription stuff. I know how to boost somebody's immunity. I know how to stop the virus from multiplying as readily. So there's some alternative therapies out there too. But there's nothing else. Yeah, go ahead.
I was just going to say, Dr. B, this is a good point. We had a couple questions come in, and I think this is a good point for you to maybe answer some of them. The first is, I think there's a misconception publicly around what is the antibody test. And so Eddie asked a really good question in that when you say antibodies, is that the RNA testing? And that's really a 2-part, because, you know, again, I thought maybe this test was for somebody who's healthy, who wants to find out if there's an immunity factor with COVID. And so could you maybe address those two questions for us?
Yeah, I'll elaborate on it. So the gold standard is a nose swab or nasopharyngeal. So nose or pharynx is the throat. That's the gold standard. When you get a sample from that, that's the RNA testing. You're getting a piece of the virus, the RNA, and then they amplify it through PCR. They're amplifying it, so then now, oh, okay, we picked up some substance, and when we amplified it, we found the virus, right? Even that test should not be done too early. So people have to have a little bit of patience, because just like when you have a sore throat, you don't know if it's a virus or it's a strep or a mono. Give it a day or 2 or 3, and you may find a common cold, the sore throat goes away, and then you get a runny nose. So, if you go too early, you may even miss the test, right? That applies to COVID as well. When it comes to the nasal swab, the magic number is, if you don't have symptoms, you may not even want to do a nasal swab, because now we realize the yield is very, very low. If you have no symptoms, to do any kind of test, the yield is very, very low. I know people were gung-ho about getting tested, getting testing. I'll get to the blood testing, which might have some value in that regard. But now we know that getting tested too early is not the way to go. So if you have symptoms, wait a few days, because you're more likely to get a positive test. In other words, you're less likely to get a false negative. So a negative test does not mean you don't have the infection. Did we hit the swab in the right place? Did we wait the right number of days? So that's, I see why there's still going to be some variability between clinicians, but as we start to present more, as more information comes in, it becomes solidified, we'll know. So the nose and the throat is where you get the culture. When you get culture, that's detecting the infection. With the antibodies, there's 2 types. There's the IgM antibody that comes after about 7, 8 days, but it can come as early as 5 days, as you'll find out. But by 7 to 8 days, the IgM is the acute antibody that comes up during an acute infection, right? So it can be used, but if you test too early, you might get negative test. After 2 weeks is when the IgG antibody comes up. That means that the body has mounted enough of a response to fight the infection, sending its own antibodies in the form of memory, right? IgG is memory. When you get a vaccination, you expect, so as a physician, when we were in residency, we had to do hepatitis vaccines. To confirm that we had our vaccination worked, we measured the antibody levels. And if the levels weren't up, then we'd have to go get boosted, because the levels going up is an indication of immunity, which is what we're hoping with this virus, right? We want the immunity. So if you were exposed and you get IgG, oh, okay, I got exposure, so that means that maybe I've got some immunity. That's IgG. You could have had it 2 weeks ago or 2 months ago, and maybe even 5 months, because COVID has been around for 5 months. We don't know how long it will last. Probably, like most things, it will last about a year and maybe longer, and we'll see if those people are immune. So the nasal swab is for the acute infection. Wait at least 3 days of symptoms before you get that. That's still the gold standard. If somebody comes to an office and we do a blood test, if you're lucky, which I was, because I waited until symptoms of 5 days. So I said, I'm going to draw the blood test for the IgM and the IgG. So the point is, we picked up the acute stuff. And I could have done the nasal swab as well, is what I'm saying. So if the blood test was negative, then I can go back and do a nasal swab just to be on the safe side. Hopefully that kind of clarifies it a little bit. We'll go to the next slide. Yep, go ahead.
It does. I just want to be clear as mud, as they say, Dr. Habib. So with the blood test, does that allow you to know that you already like you have the antibodies, so it will not, kind of spread within you? Like, is that an immunity test, or is that something different?
So the IgM is infection, IgG is immunity.
Okay, so you can test for immunity though.
Yeah. Yes. Okay. So that's where we're saying that, well, what if they have no symptoms? Can I get a blood test? Yes, because if I see IgG, that means you may have been exposed 2 weeks or 2 months or 4 months ago. You've been exposed and your body's built the antibodies up. Your body has produced antibodies, which may give some immunity.
Gotcha.
And what we're finding also is that some people who were infected and the symptoms were so mild that they never mounted an antibody response. Does not mean that they weren't exposed, but it was either so mild because their body was so strong that they pushed the virus out, or it was a very mild infection, so there was no need for the body to make significant antibodies. You can have a negative test there.
Gotcha. And we've got a couple more questions. One, I think is good to talk of right now. The other two, I'll come back in a little bit. The is it protozoa? Protozoa. Yeah. Is that, are you meaning a single cell organism when you say that?
Yeah, so the treatment is for diarrhea, and that's for against the protozoa. What they found is that it was effective in this scenario, because a lot of discoveries in medicine is by accident. And the classic one is Viagra, because they were using Viagra as a blood pressure pill. And what they found was that it wasn't working too great to lower blood pressure, but it was doing something else. So this is where they're doing the diarrheal treatment, and they found, whoa, I'm assuming, they found that, hey, these people are not getting COVID, or these COVID patients are getting better really fast. That's how they found it, they discovered it.
Gotcha. Thank you.
All right. So, so the initial set of labs were trying to figure out what's going on. I couldn't have asked for better labs. So what I put on the left side is the testing that were positive. I didn't put every test because they were normal, like the blood sugar and the white cell counts, they were all normal. So I didn't put them up there for you. But on May 28th is when they first came in with the infection or with the symptoms to me. And at that point, they had at least 5 days of symptoms. And so by the time I had started the treatment, within 3 days, they felt better. But I waited until June the 5th, which is about 8 days, to recheck the levels, because some of the information that was coming out from the Far East is that not only were the patients getting better after 3 or 4 days, the viral load was actually very low, and the testing was turning out to be negative. A positive test reversed to negative with the treatment, and that's what we found too. We found that the positive test of 60, even though it hadn't come down to normal, was almost half. It had come down to 36 within 8 days. So it'll be interesting to say, repeat the blood test in another 10 days. I don't think we need to. I see where we're going. We've got this patient who was diagnosed with COVID, has improved with the treatment, and the antibody, which is the one that for the infection in this situation, has come down. Not only did that happen, the liver enzymes, the AST, ALT, both came down within the normal ranges. And so on the right side, I've got the reference range, what we can consider normal range, the reference range, and they've fallen straight into the normal range. And what was amazing is that the inflammation marker, which people know as C-reactive protein, I do what's called a high-sensitive C-reactive protein. That means that sometimes I may see even more inflammation than a regular person, but that was quite high at 9.4. Anything under 3 is normal-ish, over 3 is high, but it was 9.4. And within 8 days, it's come down to the normal range, or certainly much lower. And that's pretty impressive to show that the infection is down because the patient felt better, but some people might just say, that's luck. That's fluke. Maybe it wasn't COVID. Well, yes, it was COVID, and yes, it was positive, and it was confirmed with additional parameters like inflammation and liver enzymes, which we know are elevated during COVID, and those, it couldn't have fallen into a nicer place category. So, so that's the before and after, and I think that may be the last slide. So I'll just put my ugly face back on so we can make some face contact here. And all right, so yeah. So look, I mean, I wanted to keep it simple. I didn't want to make this into a medical lecture, but if people want to know a little bit about the virus pathology, how they multiplies, and what you can do to prevent it in the first place, feel free.
Yeah, no, thank you, Dr. Habib. We've got a few other questions. One was your thoughts around timing of an antivirus or a vaccine, and if you have anything just kind of inside, knowledge about where that might be, or how long something like that actually takes to test and feel safe about it.
Without getting political, I would just tell you that it's become murky because of the politics that's going on. And whether you're on one side or the other, you know that there's a lot of politics going on. So whatever I'm saying, I'm saying as a physician, so don't be a hater. I'm just going to say it the way it is. And I'm a pretty vocal physician, so I'm just going to say it the way it is, based on not ignorance, knowledge. I keep up to date with these things. And as you see, I'm practicing my medicine. So this is not me reading. I'm actually doing it. So I'll give you my opinion. Let me start with where people understand. Flu vaccines. It's at best 40% effective. That's also an RNA virus. Why is it only 40% effective? It's only 40% effective because we're trying to predict the virus that is coming from another continent when they're going through their flu period during the winter months. So when it's winter in Australia, it's summer over here. And then that winter will come to us. And when it's winter in America, it'll be summer in Australia. We're trying to predict which flu virus is coming in. By the time it comes, we have to have the vaccine ready. And that should tell you a lot, that the virus changes a little bit. And that's why we have 40% at best. With that information in mind, knowing that this is the same virus that comes year after year after year, you know, it's still pretty amazing that we don't get 70%, 80%, 90%. I'm not blaming anybody. I'm just saying it's a tricky virus. And so, and that's what happens with RNA viruses. They tend to they have an ability to sort of change, be like chameleons. So it's very difficult. So the thing about a vaccine, that even if one is ready by the fall, and this is what's in the news, so I'm just going by what I heard in the news, that some people believe a vaccine will come in. But first of all, we don't even know it's effective. You have to deliver it, and you have to wait over a period of time. So first, is a vaccine even going to come out? And hopefully they'll maybe take 2 or 3 vaccines that they think are going to work. Because the reason why they say years for a vaccine to come out, because they go through all this process before they actually bring it to market. But right now we're in, you know, emergency situation. So maybe 3 products might come out and they'll get them out in millions of doses. But that doesn't mean they work. They believe it works. It's only when you then vaccinate millions of people, then you'll have an idea. So that's where, even if you have a vaccine in September, October, doesn't mean it works, and you won't know the results until well into, you know, next spring, maybe, potentially, or longer, right? And I'm not trying to, you know, not be confident building. I just think you need to be prepared, right? Prepared for the best scenario, be prepared for the worst scenario. Now, that's common language in the medical world. We always prepare for the worst, and then we hope for the best. And with epidemiology, you must always prepare for the worst and say, you know, that was overkill, because that's how it works. When you let the numbers go out of control, good luck trying to hold it back. That's what vaccinations are for, is the hope that you give it to a lot of people and be like overkill to try to, you know, mitigate what could be devastating. And
yeah, I appreciate that, Dr. Habib. That's a good information, and it's realistic, and it's something that, you know, so with that in mind, do you think that just, you know, taking appropriate measures like social distancing and, you know, wearing masks in public and things like that, do you think that needs to continue in order to slow the spread? And it, you know, at least in our area, it seems like it's worked to a certain degree. I think cases and deaths are definitely trending down and going in the right way. Just curious to see, like, until that happens and we have the data, what do you recommend that we do?
Yeah, I think the common sense approach is following the CDC recommendations, which is fairly universally accepted now. And whatever your opinion is I think that the best times to wear the mask is when you're exposing others, right? So if you have an infection, wear the mask. You're not going to give it to somebody else. If you're wearing the mask, you can't get the droplets into your airways. Now, the hands is interesting because I see a lot of people wearing gloves. Now, whether you're wearing gloves or not wearing gloves, if that hand has the virus and you get it in anywhere near your face, you're going to get the infection. So gloves are only as good as what you do with them. Like, you know, when you get in the car, better come off, because if you're wearing it on the car, then now you've now contaminated the steering wheel and so forth. So I would say masks were always the first choice. In fact, they brought it up that why didn't we recommend masks at the beginning? Well, the CDC's response, and actually Fauci's NIH, right? Fauci was saying that, well, there were so few PPEs, protective gear, that we wanted to preserve it for the first line people. That's not only the N95 mask, but also just any old mask. There was just a shortage at that time. I don't know if that's true or not. That's what he said. So I would say that on day one, I always said, if everybody had a N95 mask, so it's not too late if people are listening. If everybody had an N95, you could go to work and never worry about anything. If you had an N95 mask, you could go grocery shopping and not worry about anything. You could go to the gym and not worry about anything. But the problem is, even to this day, I'm not being political, I don't think everybody can have an N95 mask. Only if you're a Next Health client, you can have one.
That's true.
Commercial plug there. No, you can get them now. Now you can get them. Obviously, they're a little bit pricey. And what I've done is actually set up a protocol for certain corporations. So, and that goes back to, so let me give you that protocol. The protocol is follow the OSHA guidelines. The OSHA guidelines says things like social distancing, wear the masks, right? Particularly in public places when you come out the house. And then what OSHA is trying to do is set standards for offices to get temperature monitors in there, get certain humidifiers. And so right now there's technologies in UVC light. So you can prepare the office environment before people go in there. Will that immunize people? No, but it reduces the risks of you entering an area that the virus could be in, right? Then using special filters that, not filters, air purification modules, which are used by NASA, which they use not only hydrogen peroxide to recirculate, clean the air. Hydrogen peroxide doesn't come out into there, it's in the machine. So as air goes into the machine, the hydrogen peroxide negates the viral particles. In addition, it uses UVC light, and then the clean air comes out. So you can use just UVC light, which is being used by the subway stations in New York. And so you can prepare that environment. Then I say the one step further is, monitoring, right? So if these people in the workforce get testing regularly, you can quickly pick up who turned positive from a negative. Then you can give appropriate advice, right? In combination with, say, self-measurements of temperatures at home. So, we will have an algorithm where if they have Bluetooth technology on their heart rate monitor or the temperature monitor, we will be able to pick up changes before they even come to the workplace, right? You don't have to wait for a fever of 101. You could probably see a change. So these are things that are coming that I think that will build up the confidence, not only for the workforce, but then can be implemented in the civilian place as well, right? More broadly. The next step I would say is that if you can keep your immune system strong, and I'm going to give you some evidence here. What we have found is that the people that get the virus and have mild symptoms don't shed as much in their asymptomatic period, right? The debate right now has been, oh, well, people can spread the infection when they're asymptomatic. Well, how do you know you're asymptomatic? So that's why everybody should wear a mask, and that's fine. All I'm saying is that how is it that the people that have lighter symptoms have fewer viral load and fewer and less contagious compared to people who develop worse symptoms, who are more contagious when they're asymptomatic? Why is that? Because one has a stronger immune system and the other one has a weaker immune system. The stronger immune system doesn't allow the virus to multiply. If the virus doesn't multiply, either you have no symptoms or minimal symptoms. And whatever symptoms you have, you recover faster, and they're showing you're less contagious. Conversely, you don't believe in taking a vitamin D, you don't believe in taking nutrients, that's perfectly fine. But the people that could not slow down the viral replication, they get worse symptoms, and they're actually more contagious during that asymptomatic period. So my advice is, for people who doubt what I'm saying, is I do everything on metrics anyway, as Eric knows. So just like I showed metrics about my COVID patient, I show metrics about my vitamin D level, I show metrics about my zinc level, about my, any level that I'm going to recommend will be based on metrics. Now, not everybody can afford it, so then you just have to take my word for it, because I'm a clinician that has a lot of experience. So unless you want to fork out, $1,000 for a very good test, you can actually just listen to my advice. And for people who are doubters, just come on in and let's get the testing done and we'll talk about that. So I think that proactivity is what's missing. And the good news is that the people have moved on. They're not waiting for the CDC or the NIH to make a recommendation. What the new study is showing is that people are not going to see their doctors, but they're more involved in their own health care. And that is really, really promising, because that's the way to deal with everything. But now, because we come to a crisis, people are seeing that if they make the changes, not only can they prevent COVID, they can mitigate it, they can minimize it, but anything that boosts your immune system will lower inflammation. And as you know, inflammation is the driving force for heart attack, arthritis, dementia, you name it. And that's why indirectly, this is a perfect time to take control and not only deal with COVID, but make your body in a state where you can actually slow down all disease processes.
Could not agree more. And we can spend a little bit of time at the end. I want you to just tell people, because we've got some new folks on this call, some of the things that you can do to boost immune systems and the actual, process of doing that, and why in the testing. Just a couple other questions, Dr. Habib, that came in. So can you speak to COVID-19 cases that have required and the potential around the immunity of those folks who have gotten COVID and then recovered from it? What does that mean? Is there any data that's coming out on that, and what that means for folks that have had it and lived to see the other side?
Yep. So the question is, do we have evidence that if you get exposed, and do you have some immunity? Well, I think we haven't answered it, but I think we have, because they're using the plasma from infected patients and using it as plasma therapy, right? You then multiply those antibodies and give it to the sick patients, they're getting better. So I think it's promising that anybody who's been exposed to the COVID and then they build antibodies, not everyone's going to make antibodies, because if you have a very mild symptom, it's not that you have a problem. Maybe you're actually ahead of the curve. Your virus never got further because you have such a strong immune system. So that's always superior. But the people who suffered and then they build antibodies, they're now using that serum to give therapy to people with the infection. So I think that the fact is that it will turn out to be the case where if you've been infected with the COVID and you have antibodies, you're going to likely have some immunity. That's our belief, and that's what I think it's showing. But we have to wait until the studies actually come in to confirm it. But that's what I think is going to show.
That's good. We've got another question. So the monoclonal antibody?
Yeah.
So the question is, it may not work as it attacks a specific antigen, and as you said, the virus keeps mutating, so it's evading that attack. Can you share some? Is that true that it's evading its own attack because it's mutating within your cells?
I think here we're talking about therapies, right? And so
yes.
The question is about monoclonal antibodies, if it's going to work or not work. So without going too deep at this level, I would just say that there is no treatment that's 100% effective that I'm aware of. Okay, so of course we would love some treatment to be 100% effective. So I think preventing is still the number one way, and that's with washing your hands, social distancing, the mask. The second one is be a very strong host. The strong host means that the virus is going to pick the weaker guy. And so that's where, and we're going to talk about how to boost the immune system in a second. And then, as I gave you an example of one of the ways to treat it, I'm not saying this will be the final way. The other one was where they take the immune cells from the recovered patients and amplify it, multiply it, and fuse it, and the people have recovered. And now you know that the intravenous steroid for the ICU patient who's on a ventilator, there's 30% less deaths with the ICU patients. The ones that are not on the ventilator that are requiring oxygen, there is about a 20% improvement in outcome there, in fewer deaths, should we say. So without going into specifics on those things, because for this conversation, let's talk about immune boosting. I break it down into two ways, right? The way that the acute one that works quickly, and the one that you have to invest a little bit of time to build up the levels to get the full impact of that. So two of the most important ones that can be effective at the early onset of an illness is very high dose vitamin D. And so I'm loath to give you doses because in a format like this, I'm not supposed to diagnose and treat. I'm giving you information that you go to your doctor. And so if you want specific information on the dosing, then reach out to me. Now, not only would I do the vitamin D and other vitamins I'm about to go over, but as I said, there's other novel treatments that actually shorten and kill the virus within a few days. The next one is vitamin C, which can work fairly quickly, but at a different level. See if you can follow me. When people are sick, the vitamin C level drops. So by taking it, you're bringing it up to what it should be so your body can work well, right? But is it by itself strong enough to overcome the virus? Don't know, not sure about that. Now, let me tell you why I don't think it's enough to work, because in my experience, it hasn't worked for regular virus, and with COVID, we haven't tried to do it with COVID, should we say, which is that in the animal kingdom, like the sheep study showed that when sheep get sick, they produce their own vitamin C 100-fold. Humans have lost the ability to make the vitamin C. So when you're sick, the vitamin D at very high doses for maybe 3 or 4 days for a regular virus, But for the COVID or flu, I would take it for 5 or 7 days at very high doses. So for people who sometimes get shocked, it's like, I'm only saying 5 or 7 days. You're not going to get toxic on 5 or 7 days. And if you're worried, get the level tested afterwards. We're talking about therapy, not based on levels, it's therapy to get better, right? You don't wait for levels. You just take something, because by the time you wait to testing, you're already sick and the virus is multiplied. So those are the two that I think could work quickly, particularly vitamin D and then vitamin C for the reasons I just said, because the animal world can make it. We as humans can't make vitamin C. At least give yourself the vitamin C that would be therapeutic. And then, in my office, I can do very, very high doses in multiple different ways. The second ones are the things you may have heard, right? You may have heard of the zinc. Now, zinc and hydroxychloroquine is where the combination. So the hydroxychloroquine helps the entry of zinc into the cell. So there's still some validity there. We'll figure that out. I'm not pro hydrochloroquine. I'm not against it. I'll just give you the data. But zinc is undoubtedly a good nutrient that stops the virus from multiplying at a certain level. Vitamin D stops the virus from multiplying at a different level. Quercetin stops the virus multiplying. And so each of these antioxidants have a different way to stop the virus from multiplying. It is not a treatment. It doesn't make you feel better all of a sudden, but it's a way to make your defenses stronger. However, the problem is you can't take it when you get sick, because zinc cannot enter the cell so rapidly. Unlike vitamin C, unlike vitamin D, they can enter the cells rapidly, but zinc cannot enter rapidly. Quercetin cannot enter rapidly. Magnesium cannot enter rapidly. So you have to be a little bit proactive. So that's why with boosting the immune system orally is either the short-term boosting or some more investment, more time to build up. And I haven't even talked about a good diet, right? So before that, I always tell people when we have the right time, I always say you must sleep properly, because that's the #1 way to damage your immune system. Lack of sleep in animal studies after a month showed that mice became diabetic, right? So lack of sleep is not just a wishful, luxury that you wake up and you feel great. There's a lot of biological and immunological consequences of not sleeping. So #1 is don't damage your sleep. #2 is don't put the bad food into your body. Processed food, chemicals, coloring, preservatives, these are neuroirritative. They will make your sleep a disturbed sleep. So you may sleep 7, 8, 9 hours, but you will wake up unrested. That is the definition. Now, how does that happen? Maybe from complex mechanisms, but we know that these processed foods, they stifle the bacterial flora. When you don't have diverse bacterial flora, then your body is more inflamed, your immune system will be compromised. And they say, science is pointing that it can happen in as quickly as 24 hours, right? Sleep deprivation, damage in 24 hours. Bad diet, damage in 24 hours. And then we have to say, putting in the good food. Again, there's some short-term benefits, but it's really long-term benefits. Short-term is calories. Short-term, it's the buildup of amino acids, the buildup of the essential fatty acids, the buildup of the minerals and nutrients. They don't spike up and down. The only thing that spikes up and down is electrolytes and glucose. So if you're taking potassium, that's going to go in very, very quickly. But don't expect magnesium to go up and down like this, because your cells will become dysfunctional. They wouldn't be able to operate very well. So that's why a good diet is to build up the levels. Supplementation as a whole is to build up the levels after your good diet. A good diet has the whole food, which has the enzymes and the cofactors for most effective absorption and function. And then supplementing is useful in the hands of somebody like myself who knows how to complement that. You never replace the supplement with a good diet. You never supplement the supplement. You don't replace supplements with sleep and so forth. You have to follow those orders. So sleep, don't put the bad food in, put good food in, and then supplement. Of the supplementation, once for acute, once for building up, just like diet.
Fantastic, Dr. Habib, and just it's not as hard as people think it is. It's just consistency. And we had a good question come in. I want to just have you address this. So for those in the crowd that are 60 years old or older, there's, noticing that they just don't heal as fast anymore. And so what type of recommendation do you have to help healing with older people, particularly in internal areas where maybe they can't see? Is that also those 5 core principles you just talked about? I'm sure that can't hurt, but what would you say to our folks on the call that are a little bit more seasoned and wanting to heal as fast as somebody in their prime? And I know you're going to say there's no reason why you can't be in your prime till you're 80, and that's certainly my goal, but you elaborate on that for us, please.
I hope to do that. So the question was, somebody who's 60, you may not be healing as well. Can you do something proactively? So I'll start off with where you were, is that you may be 60, but biologically you could be 80. Conversely, you could be 70. And I know somebody in the audience who I know very well, and she knows I've said this, is that biologically you could be 80. Your chronological age could be 80 plus, but your biology could be like a 60-year-old. So really, it's your biological age. The people who are biologically advanced in their age are the ones that, wait for this, it's rocket science, they don't sleep so well. They eat the wrong food. They don't eat the right food. They don't exercise. So really, you're creating your own environment, right? So it's really not age. Of course, it's in medical professionals, we have to use age because the average people, for the average population, it does make sense. But maybe in the future, we will not use age because we'll become much more sophisticated. So the question is, how do you stay biologically younger, right? And so the adage is, you're as old as your blood vessels. So some of the key things that we already mentioned actually protect your blood vessels. So when you take vitamin C, you're actually protecting your blood vessels. You're reducing inflammation. You're actually making the connective tissue stronger at the blood vessel level and every connective tissue. So being proactive is a way to boost your immune system. But really what we're saying is that you're actually making yourself physiologically younger by taking these proactive steps. So I would say I would start with, what is your biological age as opposed to your chronological age? And taking a good history can tell you a lot, but there are other sophisticated ways that we can go into that. And so the aim is that anybody could take the supplementation, but measuring the levels is useful because, like, for example, I just did a full panel of intracellular vitamin levels on my wife, and I found that her omega-3 level was very, very good. So why am I going to waste my time torturing her, making her swallow omega-3 pills that you might belch at after your meal, when I can focus more on the vitamin D and the vitamin C and the B complex, right? So, I think measurement, people get afraid of measurement. Sure, it can be costly, but really, when you do the right test, it's actually it's more economical in the long run. So the analogy I have is that the person that's gone to 20 doctors with their copay and they've got done through the insurance, but they didn't get better. What a waste of time. What a waste of effort. What a waste of money as well, because I'm sure they had testing done, but you just did the wrong testing. So I think the testing is not just a plug for testing. It's like, let's use evidence-based where possible. Now, if it's not possible, then you have to use people's clinical judgment like myself. So from the history, I can oftentimes figure out, what's going on with the systems. And then the lab is to confirm what I'm thinking or refute what I'm thinking.
Yeah, that's, the key in my experience has been the testing. And for those of you who do not know, Dr. Habib does the best physical, executive physical in the business. It's not even close. And really the future of healthcare and what I think will save our country from tremendous debt is in concierge personalized healthcare. And the testing is key to find your own roadmap and your own blueprint for what matters for you. And one thing you didn't mention that's so critical is the food inflammation test. You may think you're eating healthy foods, and you are, but based on your own diagnosis, that may be causing inflammation to you. And we had a whole presentation, so I won't revisit it, 2 weeks ago on inflammation versus food inflammation and how both of them come together to hurt you. But the key is the testing. And so I would encourage all of you to independently reach out to Dr. Habib if you haven't and inquire about the testing and what it looks like. The more we can do preventatively now is great, because I think the reality is, and Dr. Habib, you can comment on this too, even after we get through COVID, the more prepared we are for future pandemics, and the more we're saying we need to not necessarily put all our trust in, government and everyone else to help us, the more prepared we are just individually, the healthier we are, the things we do day in and day out to create a healthy immune system to be able to handle these things as they come in and be the stronger one that it's not going to be able to spread in, the better, whether it's COVID-19 or COVID-22 or whatever comes in the future.
And so this is a very important point that I want to say is that, when people take the control in their own hands, it's going to be far better because of all the tools we just described, there's no perfect tool. The vaccination won't be perfect. The treatment may not be perfect. So I think that instead of trying to demonize, wearing masks, no masks, and I think that the more tools available, it's just common sense that you're going to get better results doing that. And the second part that you brought up is, when we talk about people who end up dying, and majority of them, 99% of the Italians that died had at least one pre-existing condition. And so up to almost 2/3 had like 2 or more pre-existing conditions. But of the pre-existing conditions, like diabetes being one of them, heart disease being one of them, they found that blood pressure was the one that caused the most deaths. Now, let me bring that back to the question you said about the 60-year-old person or somebody who needs to be a little bit more proactive. If you have inflammation, you will get older faster. Inflammation will damage your DNA. Inflammation will damage your blood vessels. Inflammation will damage your brain. So inflammation is the fastest way to get old. And the things we just talked about, how to stay healthy and the preventative, whether it's the polyphenols, the vitamin C, the antioxidants, they all protect the blood vessels. So, when I deal with blood pressure, I deal with it not at a numerical level, is why is the blood pressure up? And I look at all these deficiencies, these inflammations, and see that all the pathways are working right, and the blood pressure inevitably comes down in greater than 90% of the population. And I propose to you that if that's the case, then those people won't be affected by COVID like somebody else that may even seem to have normal blood pressure, right? Because in the people that I have with normal blood pressure, I see that significant number have stiff blood vessels. So in my mind, they're not even normal. So the point is that protecting your blood vessels will protect the rest of your body. We know that the age of your blood vessels will determine risks for cerebrovascular problems. That means stroke or dementia. It will also have overlaps with cancer prevention, because when you have good blood vessels, there's no way you're going to have inflammation. You're not going to have the kind of damage to the DNA that is seen. Now, I'm not saying inflammation is the cause. I'm saying it's one of the major factors that is destructive, and it's easily reversible, unfortunately, without a prescription. It has to be done naturally for now.
Fantastic. I think we answered the bulk majority of the questions. We've got about 2 minutes left. Anybody else have any questions that they would like to ask Dr. Habib, specific to any of the things we discussed today, or concerns around COVID, or things that you can be doing? Speak now, or forever hold your peace until 2 weeks when we do this again. Okay. Dr. Habib, as always, this was fantastic. Again, my name is Eric Goloniak. Please feel free to reach out to me via LinkedIn. Any ideas or thoughts you have on topics or takeaways or things you want to see Dr. Habib do or talk about, please feel free to let me know. If you have not started following Dr. Habib on social media, you're missing out. He is my favorite Instagram follow, and that's saying something. I have quite a few great ones. He's outstanding, constant content that is valuable. So please, I encourage you all to follow him. Look him up, Next Health, office in Ashburn, office in Bethesda. Reach out to him with questions. He's fantastic. Eddie, do you have something?
Website address. Dr.
Habib?
Yep. I should have a slide right here. It's www.nexthealthmed, N-E-X-T, healthmed.com.
Excellent. Great presentation. Thank you so much.
Oh, Dr. Habib, we have one last question come in. What do you recommend to take with zinc?
So personally, I like a more global approach. So zinc and I think quercetin would be a very good combination. Vitamin C and fish oil. Again, you're not going to get the benefit of the fish oil right away. But I think that those are something that you should keep on as a good combination.
Yeah, and for those who don't know,
which fish oil specifically? Because I see there are tons of them at Whole Foods.
Yes. The good news is that we've moved on from that debate of is it good, is it not good. So almost all of them are good. It's about the amount. So I would just say that for most fish oils, 2 tablets, capsules, it would amount to at least 2 grams. And for people who are a little bit more sophisticated about deciphering the different fish oils, we're really looking at the EPA DHA. So omega-3 is fish oil, 2 tablets will be fine. And most of them are reasonable. Like with vitamin D, most of the over-the-counter vitamin D is D3, which is even better than the prescription, by the way. And then for the people who want to decipher the quality of the fish oil, the EPA protects blood vessels and over 600 milligrams. I said I wouldn't go over milligrams. Anyway, I'm not treating anything. I'm just recommending something. So the DHA protects the brain. And again, about 700 to 800 milligrams, just a little bit higher. And so I found that even though I eat a lot of fish and my level was okay, but if I wanted additional support for my brain, because the fish oil is an adaptogen for the brain, it's also building block for many, the cholesterol is a building block for many hormones, that I would just say that taking higher doses is actually a better idea. And if you really want to know quality, it's the EPA and the DHA, the concentrations.
Thanks. That's great.
And for those of you that don't know, Dr. Habib has a whole line of supplements called Next Whatever. I personally take the Next Omega and a bunch of other immune boosting stuff. Would highly recommend you reach out to him. Dr. Habib, we had a couple more things just really quickly. Ruth asked if we could, if there's access to the inflammation. I really think we should just redo that one again, inflammation and food inflammation. So Ruth, I think the best thing for us to do is redo that presentation. There's a lot of interest in that, and we'll put that on the books really soon and make sure that you get an invite and that you're part of that. The other thing was, Dr. Habib, do you have a slide that you can put up that just has your email and web address for everyone? Is that possible?
Yeah.
Yep.
Okay. There's the right-hand man.
Literally.
This is what we call on the fly.
So JR, here's Dr. Habib's information and website, email, and phone number. And that phone number is available for texting. Yes. And you can text on that phone number, right, Dr. Habib?
Wait, finish that phone number one more time. There's a missing number.
I think we're missing one number on the end of that, Dr. Habib.
4,000.
10. There we go. And you can text on that, correct?
Yep, you can text.
Great. I think that's it. Thank you so much, everyone, for being on the call and making it interactive. Thank you, Dr. Habib, for sharing an hour with us, giving us the best info we could get. And please reach out to Dr. Habib. Feel free to reach out to me. And we look forward to seeing you 2 weeks from now.
Hopefully on the balcony at the club.
Yes, hopefully on the balcony of the tower.
Thank you so much.
Thank you. Look forward to that.
Great job, Dr. Habib. Thank you, Eric.
You bet. Thank you, guys. Have a great rest of your day.